also gave the same result, no reduction of stroke risk. And the new in 2024, in this month, the Arcadia trial was released, and they compare patients with cryptogenic stroke and having atrial cardiomyopathy with no evidence of AF. They compared the epexapan against aspirin, and also they found no reduction in the stroke. So in conclusion, none of the ACEs trials showed reduction of ischemic stroke incidence with NOAC versus aspirin in patients without known AF. And a recommendation of temporary off-label NOAC might be considered in high-risk patients and in case of recurrent ACEs. However, intensified screening for atrial fibrillation, either by Holter monitoring for 30 days or implantable loop recorders, should be mandatory in order to confirm the indication of anticoagulation. The more you record, the more you will find. Left atrial cardiomyopathy and atrial fibrillation, this is the second clinical implication. The relationship is always bidirectional. The more cardiomyopathy, the more AF, the more AF, the more cardiomyopathy, and so. And it's often assumed that left atrial cardiomyopathy usually precedes the incidence of AF, and it causes the lone AF, which is the AF without any explanation or comorbidities. Atrial cardiomyopathy doesn't, of course, we should know that atrial cardiomyopathy does not recover even after successful catheter ablation for AF, and still carries the same risk of strokes and recurrent AF. So how to diagnose left atrial cardiomyopathy? To date, there is no recommendation of a specific single tool to diagnose the left atrial cardiomyopathy for the clinical diagnosis. But we can take it from the pathophysiology, as atrial fibrosis can be diagnosed using the MRI to find the late gadolinium enhancement, PET CT, and elevation of biomarkers of inflammation and fibrosis. And the mechanical dysfunction can be assessed using the echocardiography to measure the strain and volumes and thrombus. Mechanical dysfunction using the always can be assessed by MRI and CT, and the electrical dysfunction with ECG and mapping. Rapidly, ECG specific finding that was even used in the late Arcadia trial, that we found the pronounced P wave terminal force in V1 and prolonged P wave and BIFID more than 120 milliseconds is always found, and the coarse fibrillatory waves with large amplitude, and advanced interatrial block with a prolonged P wave duration and biphasic in the inferior leads. These findings are specific for atrial cardiomyopathy even before the presence of AF. Echocardiography, the dimensions and volume. Usually, if it's more than 3.8 centimeters in female in the parcel long ax view, or more than 4 centimeters, or the index volume, if it's more than 34 milli per meter square, it's considered elevated. And always search for the thrombus, and it might be here available rather than the TE. The Doppler and tissue Doppler, we can appreciate the high pressure inside the left atrium by the restrictive filling pattern, and so, and always the prolonged pulmonary artery tissue Doppler duration, which correlates with the new AF in the tissue Doppler using. Left atrial strain, we will find reduced left atrial reservoir function specifically, and the TE that more clear to find the thrombus here in the appendage, or spontaneous echo contrast, and the velocity will be less than, inside the appendage will be less than 40 centimeter per second. Finally, the epicardial adipose tissue, usually look at it in the echo, because the adipose tissue secretes pro-inflammatory and pro-fibrotic cytokines, which promote the development of both AF and the inflammation and cause left atrial cardiomyopathy. The MRI always was used to define the fibrosis, and also to measure the left atrial volume, the strain, 4D flow, to detect the pericardial fat. And regarding to the fibrosis, the higher the amount of late gadolinium enhancement, as we can see, this points in the fibrosis, and the more we find this fibrosis, the more the left atrial cardiomyopathy is there, but it is not specific with AF. Can also result in the degenerative process and increase with age and other comorbidities, so it's not specific for AF. Finally, the biomarkers, inflammatory markers like high sensitive C-reactive protein, fibrosis marker, like the type 3 pro-collagen N-terminal peptides and atrial peptides, immunothrombosis markers, and the aldosterone and renin markers. So collectively, how to diagnose the left atrial cardiomyopathy? This paper was published last year. We find the clinical signs and conditions, atrial fibrillation, like atrial fibrillation, left atrial appendage, or even patients with stroke of undetermined cause. And we do those imaging tools and diagnostic tools to find what we have previously said. The MRI, we find delayed gadolinium enhancement, ECG with the changes we have just said, echocardiography, and ECG. And collectively, we put it together to put a diagnosis for the left atrial cardiomyopathy. So my take-home message, to date, there is no recommendation for the clinical diagnosis of left atrial cardiomyopathy. In addition, the current classification does not yet provide any guidance for therapies and prevention strategies. There is a need for a standardization of techniques and establishment of normal reference ranges for the various parameters before clinical application. The concept of atrial cardiomyopathy may allow better screening for the thromboembolic risk than the current approach of relying on the identification of AF only. In ACEs patients, NOAC does not show reduction of recurrent strokes over aspirin. And thank you.
Actually, it's very good. I don't know if it's working. I don't know if we need it. But it's excellent joke, thank you. And I learned loads from it. But not loads, but some. Just to make you happy. So basically, my question to you, I mean, what I can take from this is, and this is a question, you know, we have all these young patients who have cryptogenic stroke, we don't know why, and then they have an echo and they can't have a PFO, and they come for me to do a closure for them. Do you think this is helpful? I.e., can you add this to our OPE score where you decide to close a PFO or not in cryptogenic stroke in young adults?
I think yes, because cryptogenic stroke is, we can't find the cause, but if we have a PFO that causes paradoxical embolization, it is a cause. It is now not considered as cryptogenic as well. We can see this, there is a cause, that the PFO, if it's close.
PFO is never a cause. PFO is just there. It's present.
I know the paradoxical embolization through the PFO. If they put aspirin against NOACs, if I understand your question well, if we put aspirin against NOACs, in such a case, whether we can put it into one of the risks, yes, and I think that I would just suggest putting aspirin, not NOACs, because it is included inside the selection of ACEs patients.
My argument here is, based on your talk, I'm just trying to learn from it. There is some criteria we can apply to patients with cryptogenic stroke. So rather than jumping straight and closing the PFO, we can say, look, you know, we need to look at your ECG, we need to look at the markers, we need to look at the
maybe the atrial cardiomyopathy is underlying cause.
Exactly. So there is no need to close it if you have these criteria. That's the point I'm trying to make.
Maybe it is not studied yet, I think, but maybe it will be helpful to it may be helpful to be put under in light to diagnose left atrial cardiomyopathy as a cause before closing the PFO. It might be preventive. I don't know. Maybe. Exactly. This is.
It would not add anything in the clinical practice.
It's a diagnosis by exclusion, I think. يعني احنا لو ما لقيناش source of embolization definite, وده داخل تحت 60% as we said of cryptogenic strokes are having ACEs, strokes of undetermined source. When they give patients NOACs, they found that the risk of stroke, it doesn't decrease, and the bleeding risk were futile in Navigate ACEs trial اللي هي فيها rivaroxaban, and they prematurely abrupted this trial. So لو احنا شخصنا او excluded او لقينا by exclusion ما فيش سبب غير ال left atrial cardiomyopathy, we can introduce aspirin to the patient. And الفكرة في المحاضرة أو اللي أنا لما قريت كل البيبرز معظمها قبل ما أبدأ أعملها، هي المشكلة إن still the treatment strategies is debatable. آخر ترايل اللي هي اللي اتعملت الأركيديا ترايل this month they recruited patients without AF و they monitored the patient after and they found that بالرغم ان جالهم stroke ما كانش عندهم اي AF و they diagnosed the left atrial cardiomyopathy with ECG changes اللي احنا لسه قايلينها والانتي برو بي ام بي elevation والليفت اتريال فوليوم كان 3 سنتيمتر بير سنتيمتر سكوير قالوا هو ده الليفت اتريال كارديوميوباثي سو احنا ما عندناش other cause they screened the patient for everything وحطوا الاثنين against بعض الابيكسابان والاسبرين and they found no reduction of risk of stroke فاحنا هندي للبيشنت عشان ما نديلوش هارم هندي له اسبرين then ده محتاج further investigation in how to treat left atrial cardiomyopathy to date there is no treatment strategy محطوطه يعني defined for patients like this. Thank you.
atrial cardiomyopathy can occur in normal heart يعني اي حد قاعد كده يبقى عنده
لازم يكون في ريسك فاكتورز
ولا في حاجه تخليني الفت نظري ان انا حتى even if not I'm searching for the source of embolic event يعني هل انا حد معين انا اسسبكت ان يمكن يكون عنده ليفت اتريال يعني مثلا زي الكارديوميوباثي العاديه الليفت فنتريكولر احنا بنشوفها بنقول في الاخر ان في ليفت اتريال كارديوميوباثي واسبابها كذا وكذا وبتاع ويبقى هو ده الايشيولوجي او ده التشخيص بتاع العيان بتاعنا طب ليفت اتريال بقى لوحدها كده كانوا كاري نورمال هارت
هو لازم يكون في at least risk factors to promote the inflammatory process and to promote the fibrosis and to promote all the pathological aspects of the left atrial cardiomyopathy لو واحد normal healthy ما عندوش اي حاجه ليه هيديفلوب left atrial cardiomyopathy احنا we search for it لما يكون عندنا clinically suspicious patient جاله ACEs cryptogenic stroke واحنا مش عارفين ايه السورس patient already عنده risk factors و elevation of مثلا fibrosis markers and inflammatory markers and so we may suspect this is a cause of stroke or any of the clinical implication of that بس العادي انما العادي why we will develop left atrial cardiomyopathy in normal patient and ممكن اشكرك okay
we have Dr. Of course. So obviously I can't introduce Dr. Hala. She's the chair of Egyptian Heart Society and Egyptian Journal, which is now have a place in PubMed and international arena. So what is that? So no, it's not that one. Okay, so it's going to be about speckle tracking in the atrium and reseeing technique and uses. So how many here in the audience who are very few anyway do speckle tracking as a routine practice? Okay, so some of us do, so you're going to teach us on that. Okay.
Thank you very much for the kind introduction, dear Professor Hussam Al-Genji, and I'm going to talk about one of the chamber that takes a lot of momentum and interest, not only for the clinician, but also for the researchers. I have no disclosure related to this presentation. In terms of the physiologic function of the left atrium, as we all know, it modulates left ventricular filling in about 31% of the cardiac output. It secretes natriuretic peptides and they communicate with the RAS system. It acts as a parameter for diastolic function, and also it works for prognostic as prognostic biomarker in cardiovascular diseases. In earlier studies, left atrial diameter was used to represent or reflect the left atrial function. And in the strong heart study that included 3,000 patients, left atrial diameter was independent predictor for cardiovascular event, including stroke, coronary artery disease, congestive heart failure, and death. Also, in earlier studies, the left atrial volume was used to evaluate left atrial function, and it was seen to reflect the severity and the chronicity of diastolic dysfunction, and it represents the glycated hemoglobin in diabetic patients. So we have to check the left atrial volume to assess the patient outcome. And that's why the recommendation of the American Society of Echo and European Association of Cardiovascular Imaging for assessment of diastolic dysfunction, they used the left atrial volume index as one of the important parameters to describe if the patient have normal diastolic function or abnormal diastolic function. As you mentioned that a lot of research was performed to investigate the left atrial contractile function using the mitral inflow and the atrial velocity, the peak atrial velocity, the time velocity integral of the A wave, the atrial fraction, the ejection force of the left atrium to reflect the atrial function. However, this method, in fact, Doppler dependent, which means that it is load dependent, which is very variable for the patient. At the same time, it will not be used in patient having atrial arrhythmias or atrial fib. Again, the left atrial phasic volume changes was extensively used to assess the left atrial function, to have the tracing of the left atrium and measure the maximum volume and the minimum volume and subtract the contractile function from this formula. However, this method, in fact, have many pitfalls and the limitation being geometric assumption of the biplane left atrial volume, and also being the left atrium is in far field of the echocardiographic examination, there usually some foreshortening of the left atrium, and again there is lack of normative data for these volumetric phases. And that's why strain was introduced as measuring the left atrial mechanics or the deformation of the left atrium during the different phases of cardiac cycle, and also measuring the strain rate, which is the rate of a change of deformation. There are different modalities used in this aspect: the tissue Doppler, the speckle tracking, the vector velocity imaging, and the 3D strain. In fact, the left atrial speckle tracking is non-Doppler technique, which is angle independent, which is important one. That track the myocardial speckle of the left atrium. However, there are some points that make left atrium differ from the left ventricle. First, it is non-segmental strain. We can't segment the left atrial wall because it is small in volume, and at the same time, there is thinning of the wall in relation to the left ventricle, so no distinction of layers. And again, the left atrial wall is interrupted by the left atrial appendage, by the insertion of the pulmonary veins, so which make it not easier one for measuring the atrial strain. What we measure in the atrial strain, we measure the three phases of strain of the left atrium: the reservoir function, the conduit function, and the atrial contractile function. We have 3 points to be measured in these strain curves that derived from left atrial tracking. First, the left atrial longitudinal strain representing the reservoir function, which is the first positive wave, the left atrial contractile function at the beginning of the P wave of the ECG, and the conduit function as the derivation from the reservoir and the contractile function. In fact, there are a lot of things to know about what is the zero strain reference to set for measuring the strain curves. It is the left ventricular end diastolic point, which is the end of diastole, to start to calculate or measure the curves of the strain phases. Also, the strain rate also can be derived from these strain curves, and giving the positive, initial positive strain curve is longitudinal strain rate, systolic, early and late diastolic strain rate, which reflect the 3 phases of cardiac cycle. We have to know that we have to be meticulous in tracking the left atrium and optimize the left atrium for 3 to 5 beats, taking the high frame rate, 60 to 70 frames per second, and the non-zoomed left atrial view. What is the normative data for, values for this strain? From a meta-analysis of about 40 studies included patient, healthy individuals to measure the normal values of the 3 phases of cardiac cycle using the strain. The reservoir is 40%, the conduit 23%, and the contractile function 17%. Now, what we use this modality for assessment in clinical application and in daily practice. This is one of the studies that try to compare the reservoir function using the strain and the conduit function in relation to the left atrial volume assessment of healthy individual. Making a follow-up, they found that the changes in the left atrial strain occurred 2 decades earlier than the volumetric changes. Not only that, but also patient having diastolic dysfunction, the reservoir function using the strain detecting early this dysfunction before a change in the left atrial volume index, left atrial ejection fraction, or expansile index. This is done in healthy individuals and in patients having diastolic dysfunction. In another study, they tried to compare the different phases or grades of diastolic dysfunction and they measured the strain in these individuals. In this nice curve, the blue one is the healthy individuals, but the orange and the green one reflecting the grade 1 and the grade 2 diastolic dysfunction. You will see here there is overlap between the two curves, which means we can't differentiate with the volume only for the diastolic dysfunction. And while in strain, the left atrial strain show increment or decremental values with increase the severity of diastolic dysfunction, and the left atrial strain was the best marker. Again, in diastolic dysfunction, also in patient having a risk profile, the left atrial strain below 23% was associated with higher NIHA class and increase the risk for heart failure hospitalization during the 2 years follow-up. In this nice study that was published in JACC 2019, they compared the all parameters used for assessment of left atrial function: left atrial strain, volume index, EA, resting and exercise E over E prime. They found that the left atrial function using the strain as measured by reservoir strain is an important metric in diagnosing diastolic dysfunction, grading its severity, and monitoring the effect of treatment. This is from the Paramount study of patient having a HFpEF. They found that the left atrial strain and the left atrial contractile strain reduced in HFpEF patient, and this was more manifest in patient having atrial fibrillation. Again, in the TopCat study that included 357 patients, the left atrium strain was predictor of this and the heart failure hospitalization. Again, what about the exercise? How the strain behave in healthy individual and the patient having HFpEF and patient having a HFrEF. In normal individuals, there is augmentation of left atrial reservoir, but in HFpEF, there is a small or minimal increase in the left atrial reservoir function. But in HFrEF, there is no augmentation of left atrial reservoir, which means we can discriminate between the whole subgroups. Again, in valvular heart disease like mitral regurg, patient asymptomatic, having a severe mitral regurg but preserved ejection fraction, the left atrial strain was independent predictor from the whole parameters for prediction of this and the mitral and the need for mitral valve surgery. Again, it is well correlated with the left atrial fibrosis, as studied with hepatopathology. There is good inverse relationship between the strain and the left atrial fibrosis. Again, also, it predicted the progression to persistent atrial fibrillation in patients having paroxysmal AF. How about if we treat the patient with pulmonary vein isolation? Yes, left atrial strain, more than 23% had best sensitivity and specificity for prediction that the patient will keep sinus rhythm after pulmonary vein isolation. It also localized where the site of left atrial dysfunction post radiofrequency ablation. If it is compared with the cardioversion, in fact, the radiofrequency will induce more damage and the reduction in the inferior and the lateral segment, which is the site of ablation. So it can characterize where the dysfunction is. Again, the rate of recurrence of atrial fib after catheter ablation during the period of follow-up found that left atrial strain below 10% is a high predictor or excellent predictor for recurrence of atrial fib after catheter ablation. Again, with the cryptogenic stroke, like Dr. Soha just said, that the cryptogenic, which is some challenge about the source of embolization and where it is. In fact, in 583 cryptogenic stroke patients, 11% were developed atrial fib. These 85% of these patients within the earlier 2 years. And when they measured the left atrial strain, the reservoir, the conduit, and the contractile function, they found that this group is significantly lower than the patient who do not develop atrial fib, which means it's important to discover the dysfunction before earlier change or atrial remodeling happened. Again, in the left atrial strain and the cryptogenic shock, it was the strain value below 21% and the conduit function below 10% demonstrated specificity 99% and the sensitivity 36% for development of atrial fib. With MRI, the left atrial fibrosis detected in patient having atrial fib, in fact, very well correlated with the atrial strain. Patient having mild fibrosis, the green curve is much higher than the patient having extensive fibrosis, the orange curve. And finally, how about patient on treatment for hypertension? This study found that there is reduction in left atrial strain in patient with or without left atrial dilatation, but fortunately, when the patient having treatment, those without left atrial dilatation have improvement of left atrial strain. So my take-home message, the atrial strain analysis, adding incremental information to the structural information provided by conventional echo indices, early detection of atrial remodeling with better understanding of left atrial function can guide the correct time to intervention just before the final fibrotic changes occur. It has particular utility in diastolic dysfunction, HFpEF, atrial fib, and more sensitive than left atrial volume change. It may play a role to assess the response to therapy and determine the success of treatment. However, there is still some limitation, require training and expertise. There is vendor variability and no normative data still available. Often use an LV algorithm for left atrial analysis in the most of the cases. And thank you.
Thanks a lot, Professor Dr. Hala, for this elegant presentation.
Thank you.
Highly informative and highly updated.
Thank you.
My question would be about the reproducibility of the measurements of the left atrial strain, and whether is it better or the cardiac MR measurements by strain for strain. In spite, I know it's we are short of the devices a lot in most of the places.
Yes, there is variability. We know that the strain imaging analysis for the left ventricular wall, which is the gold standard here for using the speckle tracking, there is a variability. It ranges between 4 up to 10%. This is actually not because of the modality, but because of the variability of the vendors and the software used for strain analysis. But in the left atrium, it is a little bit higher, this variability, because the chamber is small, the chamber is far from the echocardiographic window, so there is some foreshortening for detection of the whole wall. The wall is interrupted by the insertion of the pulmonary veins and left atrial appendage. However, it is still better than all the method or conventional method that we use it, like the phasic volume changes, left atrial volume index, and the left atrial diameter, because the dysfunction usually precedes the remodeling. In most of cases, it precedes the remodeling. So if we need early detection of outcome, so it is better to have a strain or dysfunctional parameter like strain of the left atrium. Thank you.
شكرا أستاذة دكتورة هالة. Amazing as usual.
Thank you.
بسأل مين العيان اللي أنا أصر لازم أعمل له left atrial strain study؟ يعني مش عايزة أقول روتين. Is it routine؟ وإمتى I am obliged to do it؟ left atrial strain study.
It's important question. We now started to put the left ventricular strain in the echo report to assess the left ventricular function. But so far we have no standardization for measuring the left atrial strain, the normal value, and who the patient at risk. But in all these previous studies, the patient already have a structural heart disease. Most of them have diastolic dysfunction, heart failure with reserved ejection fraction or reduced ejection fraction, patient having a mitral valve disease. So they are the category already we have in our patient clinic. But the issue is, it is a better prognostic marker. It diagnoses early or unmask the hidden dysfunction of the atrium if there is no atrial dilatation, but the patient already have underlying structural heart disease, like patient may have hypertrophic cardiomyopathy or have mitral stenosis, and the atrium is still not dilated. So this group of patients having underlying hidden dysfunction. So we have to seek for early detection before the patient to go to remodeling.
فعلا أنا بشوف عيانين بيجوا لي وعندهم structural abnormality pathological changes
والليفت اتريوم لسه ما بيكبرش. يس.
فبستغرب اقول يعني احنا
It
في
is just
المرحله دي
delayed
والليفت
process.
اتريوم لسه صغير.
Yes.
فده بقى اللي انا ابحث عليه.
Yes. It is delayed
شكرا.
process.
So I totally agree. So yes, left ventricular strain. We in the UK we have always been doing it for the last 8 years. It's very important part of assessment, especially in women.
Yes.
We have a special clinic, women with breast cancer and Herceptin treatment.
Yes.
We base the treatment on the left ventricular dysfunction strain. So this is actually it's fantastic to have it here, and it's the only so that is as regard LV strain. It's great to have it now because we always had it. We always base treatment on it.
Yes.
To answer the question, where only left atrial strain is used in clinical practice now, we use it in the UK for footballers. When footballers sign for their job, زي محمد صلاح يعني, we measure the left atrial strain because that decides the way of the training, how to monitor them, and any dysfunction of the strain, they undergo a lot of holistic investigation.
Yes.
So that decides their price.
Yes.
So
If
this
we
is
make
the
it,
answer.
if we make it a routine work, it will be fantastic. Just to put this number,
Yeah.
is the reservoir is 23 or 40
But it
because
is
this
too
is the
early.
most area. Yes.
Now it's used for professional sport people like footballers and this. So this is where the clinical indication.
This is good example too. Yes. Thank you.
I would like to present Professor Dr. Azza Farag, Professor of Cardiology, Cairo University. She will present for us a topic of 3D echocardiography for left atrial function. Would it add new?
Thank you very much. First of all, I want to tell you that I am so happy because I see Soha is backing fully physically active again, hopefully to be more fully active for the next few weeks, inshallah. Actually, my talk is already covered to some extent by Professor Hala Mahfouz about assessment of left atrial function. Actually, I will focus here about the superiority of four-dimensional technique above or in comparison to two-dimensional. So first of all, why bother about left atrium? What's the left atrium? Actually, left atrial enlargement and or dysfunction is bad because a lot of things. It means increase in left ventricular and diastolic filling pressures or the wedge pressure, and so we can call it diastolic dysfunction. It increases the risk of atrial fibrillation together, increase left atrial volume or dimension, or impairment of function leads to atrial fibrillation and with its usual adverse consequences. And of course, it carries worse prognosis in various cardiac conditions independent of left ventricular function. And sometimes we call it when atrial fibrillation develop malignant atrial fibrillation, like in patients with significant left ventricular hypertrophy, hypertrophic cardiomyopathy, or aortic stenosis. Again, left atrial size has a powerful prognostic value in different clinical scenarios. As I said, in atrial fibrillation, in systolic heart failure, takes into the prognostic assessment of patient according to the left atrial function or size. In HFpEF, it becomes one of the cornerstones for the four criteria of echo assessment of a patient to be diagnosed as HFpEF. In ischemic heart disease, in systemic hypertension, of course, stroke, and as I said, in hypertrophic cardiomyopathy, so the smaller here is better. Here it is a study in the released recently in the Nature scientific reports about the left atrial dimensions and the left atrial volume, and as much as you have larger size, either in the form of dimension or volume, you have less free event survival events. And for the first time, the European Society of Cardiology placed in the category of recommendation 2A the left atrial size in the form of volume and in the form of dimensions. This was not present in the 2017 guidelines, and it is not still not present in the American guidelines. of course, in the assessment of severe asymptomatic mitral regurgitation amenable for repair in a specific well-equipped centers. I will not talk a lot about the strain and the function of the left atrium because it's covered fully in the previous lectures, but I will tell you it is not only the story of dimensions, it's not only the story of volume, but it's also the story of function, and it is well represented as the different strain values. What's called the left atrial myopathy, which is covered by Professor Soha, of course, the condition became more worse with development of persistent atrial fibrillation. So how to measure the left atrial size? You have either diameters or dimensions, either using the single mode or the 2 dimensions. You have area with its own limitation I will talk about by 2-dimensional echo, and volumes either calculated by specific equations like the area length method, the Simpson's prolate ellipsoid by 2-dimensional equations, or the 4-dimensional echo, which is our talk. So let me tell you first that the dimensions taken here by this famous parasternal long axis is not recommended anymore, but the left atrial area measured by either area length method or by Simpson is now acceptable in all guidelines. And we have some limitations by the 2-dimensional assessment. That the left atrium, when it is decreased, it doesn't increase symmetrically in all dimensions or in all planes. It may be increased in the anteroposterior diameter or the mediolateral diameter in comparison to the other dimension. And here we have certain figures by area length method. It's not present in the previous guidelines for chamber quantification, but it's now present in 2015. And we have 2 golden figures for the normal volume, which is 34 milliliter per square meter surface area. Remember, it is here indexed to the body surface area. And we have the other golden figure, which is 48 for severely dilated left atrium. Of course, by 2-dimensional echo, as I said, we have 3 methods or 3 equations: the pipeline area length method, or the pipeline Simpson, or the ellipsoid. And as you see, there is a great discrepancy between the 3 methods for assessment by 2-dimensional echo, which makes a burden for assessment of such volume by the 2-dimensional echo. Again, as Dr. Hala Mahfouz said, that we don't have the left atrium and the left ventricle in the same plane. You must focus on whatever chamber you want to quantify. If you want to quantify the left ventricle, you must make it the left atrium foreshortened. And if you want to quantify the left atrium, you must foreshorten the left ventricle, which is one of the obstacles you can face in assessment in routine by 2-dimensional echo. Again, the left atrium is not like the left ventricle. It is not single in the diastolic area or single in systolic area, and so you can calculate the volumes. But we have 3 functions for the left atrium. We have the reservoir, the conduit, and the booster pump, and usually we measure the largest area at the end of systole, which is the end of T wave in the ECG. But you have 2 other functions for the left atrium, which is pre and at the onset of the QRS, which is the booster pump and the conduit function. So it is not easy to talk about the left atrium from a single view or from a single phase in the cardiac cycle. Again, we can make our calculations based on the geometric assumption we assume by 2-dimensional echo to assess the reservoir function, the conduit function, and the booster pump. And as you see, this is a very cumbersome equations to be assessed in routine practice. So what about the 4D? Why the 4D is being superior after talking about the all obstacles we can see in 2-dimensional echo? First, the problem of image plane error and alignment with the left ventricle and left atrium is overcome by 4-dimensional echo. And so here we don't have geometric assumption to calculate the area. We don't have left atrial foreshortening, and you don't need to focus mainly on a certain chamber to be quantified. You don't have image plane error. Studies show that the volume measured by 4-dimensional echo has no underestimation compared to the usual techniques, either the CMR or the cardiac CT. And of course, we respect the left atrial phasic function, and we can do all our calculation in a single bead acquisition. So this is a study about the real three-dimensional echocardiographic quantification of the left atrial volume. It's not a new study. This is 2012. And it shows that when you use two-dimensional echo to calculate the left ventricular volume, you don't have actually a corresponding figure to the CMR. If you can see here, the normal two-dimensional echo assessment for the left atrium was present in two-dimensional echo in 35 patients. However, in three-dimensional echo, the normal was only 9 patients. However, the abnormal patients with CMR was 80, so it is more corresponding to the three-dimensional assessment rather than the two-dimensional assessment. Again, we have a multiple vendors for assessment of the three-dimensional echo, but some of them are semi-automated and some of them are fully automated. This is present in the literature, so I don't have anything to say that the Philips and by its heart model and the Siemens by the ESI software are fully automated assessment for left atrial volume. However, the General Electric is still semi-automated technique for assessment. So my take-home message is that two-dimensional echocardiography assessment of the left atrial volume is based still on geometric assumption like the left ventricle or the right ventricle. Left atrial enlargement and remodeling used to be asymmetrical, so this fact makes geometric assumption even more inadequate and more insensitive. Two-dimensional echo underestimation of the left atrium compared with other image technique like the CMR and cardiac CT are still limitation. Three-dimensional echo is able to overcome this limitation by allowing direct detection of left atrial limits. Thank you very much.
Thank you very much, sir. Excellent talk. So any questions from? When there is no questions, means very difficult topic, isn't it?
It is not very difficult, sir, but I think that to be assessment of the left atrium by 4D echo is not a routine. We must say that this is not a routine. But you sometimes need, in addition to the strain, to assess the left atrium by four-dimensional echo.
I have a question for you.
Yes.
So I say I want to do a PhD with you, and the topic is going to be, and it has to be clinically relevant in the next 5-10 years, and the topic is going to be for the left atrial assessment. What's the topic you suggest to me?
What topic? Sport cardiology. This is
well,
one.
I'm doing
and
a PhD
HFpEF.
with
This
you.
is 2. I think these are the main 2 topics. HFpEF, because you still have a lot of drugs going to the market and may do well with HFpEF.
So you will go to the
It's a
DABA.
window of the left ventricle.
Perfect. So you will go to the dapagliflozin people who keep chasing everyone
Yes.
here, and say to them, sponsor my student. He's going to do 4D left atrial size before and after treatment with DABA for a year,
Yes.
and they will sponsor it for you. And DABA now is, by the way, guideline grade, which is very difficult to pass anything in the NICE guidelines in the UK because it's very stingy with money. Now it's type 1, grade 1 indication in diastolic dysfunction, heart failure with greater ejection fraction, and I have seen wonders with DABA in some patients, not all patients, but some patients have no response. And the question would be, would the left atrial assessment either by strain spectrography as well as size play a role, A,
Yes.
in response, B, in deciding who are the responders?
Okay.
Thank you.
Thank you very much.
Another question, please. Dr. Azza. Another question.
I want to ask me a question and I can answer.
You stated that the dilatation or the increase in the volumes is not symmetrical.
Yes.
So this would help us to find segmental changes that happens in the left atrium. When we talk about the strain, this was not.
I don't think that we can assess the segments rather than by the strain. I don't have something to assess segmental function. But by 4D, you can overcome the assumed geometry which is not present actually. You assume that the left ventricle is upon a chip. It's not upon it, especially if it is distorted. You assume that the left atrium is like a sphere, which is not the story. This is not a sphere. In addition, when the left atrium became pathologic, so it enlarged, and sometimes a lot of fibrosis occurs in this left atrium, make it more liable for arrhythmia, more liable for atrial fibrillation, whatever. So you cannot apply the geometrical methods or the geometrical assumption on this abnormal shape. So you must need to have something to overcome this problem. In addition to this, I think answering Dr. Hussein about the left atrium, when I can make it something routine. When the artificial intelligence already, which is actually present in some of our machines in the software, make the task more easy. So I can, only by one touch, make my whole assessment in one cardiac cycle. So I overcome a lot of problem about the beat to beat variation, about the timing, about the reservoir function, the conduit function, the booster function. So you can make your assessment with a high degree of accuracy with the least effort by helping the software, by the help of the software with the embedded artificial intelligence in our new vendors or new software machines.
So we're going to introduce Dr. Shaima Mustafa from Banha University about 3D transesophageal echocardiography and left atrial appendage in patients with atrial fibrillation.
السلام عليكم ورحمة الله وبركاته. I will talk today about 3D TEE of the left atrial appendage assessment in AF patients. First, what 2D TEE offer and what 3D TEE can add more. First, we will see 4 cases of atrial fibrillation referred for TEE before cardioversion. This is case number 1, mid-esophageal view, as we can see. This is here. pointer. Okay, we can see left atrium, mitral valve, left ventricle from the mid-esophageal view. Here is the left atrial appendage, the comedian range of ligament of Marshall, and the upper left mammary vein. What is this mass floating in the left atrial appendage? This is how we can see by the 2D TEE. By explain mode, first mode by 3D TEE, we can see still the mass is floating in the left atrial appendage. What is this mass? Simply by 3D, it focused on this mass, and it was found this just bridging. It was a bridge in the left atrial appendage. We can see here by grouping, it is those bridging between the walls of the left atrial appendage. So this patient can do cardioversion. There is no contraindication for this. Second case of a 62 years old man with history of CABG and AF. The patient is planned for a cardioversion, and the empty velocity of the left atrial appendage over 5 cardiac cycles, as the patient is AF, was 41 centimeters per second. As we can see, there was a mass seen in the apex of the left atrial appendage. The velocity, empty velocity here is borderlines, 41 centimeters per second. What is this mass? By X-plane mode, we see that this mass become a linear structure. By 3D, it was a bi-lobed appendage. We can see here 2 lobes, one large and small accessory lobe. We can see here the bi-lobed structure by the end face of the left atrial appendage, large lobe and small accessory lobe. Third case, which we see very frequently in the echo-lab, this sawtooth appearance in the wall of the left atrial appendage. The empty velocity here was normal, and it was a prominent pectinate muscle in the wall of the left atrial appendage. As we can see here, this is the pectinate muscle. Case number 4, we can see here that the left atrium is dilated. Left atrial appendage also is dilated with a smooth mass. This mass in the apex of the left atrial appendage. By 3D, it was a thrombus in the left atrial appendage. Here the velocity was low, it was about 20 centimeters per second. This is what 2D offer, and what is this 3D or real-time 3D can offer. By 2D, left atrial appendage is seen from multiple angles. We have to screen the left atrial appendage at 0, 40, 90, 120, and 135 to get full views of the left atrial appendage. It has no definite shape. Also, we can, by Doppler analysis, we can know the velocity of the left atrial appendage. It is more than 40 centimeters per second. It is low risk for thrombus formation, but if it is less than 20 centimeters per second, it is indicating high risk for thrombus formation. First option of 3D, by one touch, we can get the other extension of the left atrial appendage. We can see left atrial appendage here is having a short one loop. We can see by the M face the close relationship with the left atrial appendage with the mitral valve, lower left pulmonary vein. We can see the groove, the inside of the left atrial appendage with prominent pectinate muscle. We can see number of loops by the M face view, and by the cropping, we can see hidden loop as this loop of the left atrial appendage, multi loops by loops of the left atrial appendage. The total appearance of the pectinate muscle, it was so clear by 3D, and we can see here this multiple grooves by prominent pectinate muscle in the left atrial appendage. So be careful when dealing with patient with AF when evaluating left atrial appendage. We have two problems: underdiagnosis of thrombus in hidden loop of left atrial appendage, which can be missed, or overdiagnosis by misinterpretation, acoustic shadowing from ligament of Marshall, or misinterpreting the pectinate muscle with, as thrombus. The problem with this left atrial appendage is that it doesn't have a definite shape. We have different shapes for left atrial appendage. It may be with a single loop, it may be with multiple loops or bi loops. Can be evaluated by echo, by angio, and by CT. In a recent report in 2023, it was found that the classification of the left atrial appendage based on morphology was not accurate, and they proposed a new classification system based on the bend angle of the left atrial appendage. Besides, it was found that 3D TEE is an accurate, reliable, and feasible, and can be compared to CT. Here's the old classification, based mainly on the shape of the left atrial appendage. By the new classification, depended on the bend angle of the left atrial appendage, and they classified it into low risk left atrial appendage if the angle is acute, less than 90, and for high risk left atrial appendage if the doesn't depend on the shape but depend on the bend angle. And it was found that CT and 3D TEE was almost perfect for risk of the patient. A recent report in the European Heart Journal, they found another value for 3D TEE for evaluating left atrial appendage by measuring in systolic volume, and it was significantly associated with worse outcome in patients with AF. The second issue, the value of 3D TEE is during left atrial appendage closure. AF is one of the most common etiologies for thromboembolic events, and the most common site for these thromboembolic events is the left atrial appendage. Thrombus in the left atrial appendage in 90% of patients embolize, and usually the site of embolization is the brain causing stroke. So patient with AF, there was a debate in guidelines, in different guidelines, to use oral anticoagulant or with closure of the left atrial appendage. And it was found that the recommendation is less strong for left atrial appendage closure device over the other than oral anticoagulation, and if the patient is going or able to take the drugs. If he is not able or there is strong contraindication for the oral anticoagulation, it is strongly recommended to do closure device. Role of 3D TEE in left atrial in structure intervention is well developed in mitral aortic valve intervention, tricuspid valve intervention, but our focus today on left atrial appendage closure. This is animation for how the left atrial appendage closure device inserted through femoral approach, femoral vein, through the inferior vena cava to the right atrium, and the septal puncture through the fossa ovalis, thinnest part of the septum. This here the system in the left side, introduction of the system in the left atrial appendage. This is animation for Watchman device, which is one of the most studied devices for left atrial appendage closure. After release of the device from the case, takes several months to be completely industrialized, and this separates the device completely from the circulation. The role of 3D TEE pre-procedure for left atrial appendage closure, first for assessment of its relationship with surrounding structure. First, the structure of the left atrial appendage has a problem here. Its upper edge is higher than the lower edge. This is spiral form. It is not around the structure with the same plane. Second, its relationship with interatrial septum, site of puncture here in the posterior inferior part of the fossa ovalis. Its relationship with the circumflex and mitral valve. Second, the measurements of the points of the for the decision of the size of the device. We have several measurements, and these measurements are different from device to device about the orifice of the orifice of the appendage, about the landing zone, and the depth of the device. We can use 3D TEE multiplanar reconstruction for accurate sizing of the left atrial appendage device. Second step is the role of 3D TEE during the procedure. We can see here that we can use 3D during several steps during the insertion of the device. First, we can see here a tinting of the interatrial septum with the sheath here in the left atrium. Second step, we can see here the sheath inside the cavity of the left atrial appendage. Here the device is well seated in the left atrial appendage, and here after release from the case. This is how we can see the device by 2D and by 3D. This is a device including the orifice of the left atrial appendage, and you can see here this is the device including the left atrial appendage, and this is the proximal end screw which is released from the sheath of the case. The most important is its use during follow-up of patient with closure device. We can see that the patient may develop a leak, and the leak is considered, as you can see here, by 2D and by 3D. We can see the size of the leak. If it is more than 5 millimeter, this indication for treatment either by oral anticoagulant again, or by occlusion by a coil or block. It's another case with post device leak. Another very rare complication just published in J case report in 2023. We can see here the device after it is still attached to the case. Here after release from the device. Immediately after release of the device, there was a mass, thread-like mass appear here attached to the device, and it appeared by 3D, which indicates it is very rare complication. This was 70 years old female AF, just recovered from COVID-19. After 6 weeks of Avexpan, it was TEE revealed again, and revealed that the thread mass disappeared. So my message, the 3D TEE imaging is an effective tool for assessment of the left atrial appendage morphology, size, volume. Beside risk of assessment for thrombus formation, it improves the quality and safety of left atrial appendage classification than conventional 2D TEE. It allows proper evaluation of the appropriate size of the device, continuous visualization of the case and device implantation, and the precise delineation of the position of the device in the left atrial appendage. It is suitable for follow-up after device implantation for surveillance of complication. Thank you.